Thank you very much, Sarah. Welcome to part 2 of this webcast today, talking about perioperative volume therapy. And we've actually decided to do a slightly different approach, presenting you a case scenario with a simulation video showing what happens if you replace blood losses during major abdominal surgery with crystalloids in the one scenario or with colloids in the other scenario. Please enjoy the video.
I have here Michael Blackmore. He's 68 years old, he's hypertensive, and he's scheduled for open colorectal surgery. So what do you think?
Okay, he seems healthy, seems to be a routine operation. I would give him a basic monitoring, use a TIVA, TCI. I would insert an arterial line with his hypertension and it's open surgery, otherwise I think he'll be fine.
Okay. Hey, can you please help me in the OR? Hi, good to see you.
Hi, this is the bleeding patient. Okay, it's not bleeding anymore, but you can see here you still have a slight hypovolemic situation. You've obviously been giving quite a lot of crystalloids. Vasopressors are quite high. Do you think that was the best solution? So were they the best solution to use in this perioperative hypovolemic situation? If you look at the physiological distribution area of crystalloids, which consist of water and electrolytes that are not held back at the vascular barrier, you can see in blue the extracellular compartment over which these substances are evenly distributed. So 20% remain in the intravascular space and the rest is shifted into tissue. Now this physiological belief has also been confirmed in this trial using a double-label blood volume measurement, showing and confirming the volume effect that we believe from physiology to be around 20%. That means if you have an acute blood loss during surgery, you can obviously replace it with crystalloids, but you will need to use the 4- to 5-fold amount, meaning yes, you will achieve normal volemia, yes, you will replace the blood loss in your vessels, but you will also shift a considerable amount of fluid into tissue. And we all know from our daily practice, you don't even need to look at these photos, that is definitely not what we actually want to be doing and how we want to treat our patients. Using a lot of crystalloids has been shown to increase the rates of postoperative complications, decrease wound healing, prolong the stay in hospital and ICU, and also cause postoperative weight increase, which is obviously this accumulation of the fluid that we have caused to shift into tissue. You can see that there's a linear dependency between the amount of crystalloids infused in surgery and the postoperative weight increase. So the more crystalloids you infuse, obviously the more will be shifted into tissue to you. So we do have a clear indication for crystalloids. They are very important fluids. Use them to replace fluids, which is water and electrolytes, ongoing urine production, insensible perspiration, water evaporation over the skin, the airways, over wounds in the operative setting. But it's not ideal, despite you can use it, for volume therapy. And we'll look at the second scenario of this video using colloids to show you the difference. Okay, the first bag of starch is in, and you can see now that we have an improvement of the hemodynamic situation, a lower heart rate, higher blood pressure. Pulse pressure variation obviously much improved, but the blood loss was over 1,000, so I would give another bag of starch. Okay, so the second bag is in, bleeding has stopped, got ideal hemodynamic situation. This is how it should be. I think we've done a good job, well done. So the difference between these two fluids is that colloids have large molecules which are retained at the intact functioning vascular barrier. So we're obviously talking about healthy patients in the surgical setting, not about critically ill and septic patients. So these products stay in the intravascular compartment, which has also been shown in clinical trials using double-label blood volume measurements of isooncotic colloids like 6% starch 130 to have volume effects between 90 and 100%. So colloids also are very important drugs with a totally different indication than the crystalloids. As they are distributed only in the intravascular space, we should give them to replace losses which only occur in this compartment. So that is basically the replacement of blood losses, and to restore cardiac preload in the face of acute hypovolemia or acute shock. Back to Brigitte Brandstup's trial in colorectal resection, we see every patient received a basal crystalloid for fluid replacement, and then if they had blood losses, they received HEARS 130 or a crystalloid. And you can quite clearly see the effect. They dramatically reduced the amount of fluid infused by about 2.5 litres. And that also reduced the overall rate of complications, especially as a cardiopulmonary system, which is so crucial for our outcome. And you can see also the wound healing was much improved, giving less fluid, which is important in gut surgery because obviously these patients suffer a lot if they have post-operative wound healing problems, surgery. So to summarize my talk, I believe that patients need crystalloids and colloids. They are two totally different drugs with different indications and different contraindications. But always bear in mind that they are drugs and they do have side effects. We should be giving them to the right patients according to an indication in the adequate amount. So my short recommendation is to use crystalloids for a fluid replacement, and for a volume therapy in the perioperative setting, I recommend to use colloids. I wish you a happy